Thank you all for joining us this morning. I know we've mentioned in the past that as a state office, we've really wanted to take that leap and work more with our rural health clinics across the state. And so we started with kind of creating our email distribution list last year. And we got in touch with Greg to talk about what would be our most logical next steps to provide support. And so this is kind of our first big thing, and we're really excited to have you join us, and then also have Greg and Jonathan help guiding us. So with that said, I will turn it over to these two gentlemen to get us started, and they'll kind of give you an update, but as well as talk a little bit more about what's to come.
Thanks, Laura. If I could just extend your opening comments just for a minute or so, and then we'll let Jonathan start working through his content. My name is Greg Wolf, and I live up here in beautiful Portland, Maine, along with my colleague at Skywater, Jonathan Pattenberg, and we are excited for this kickoff presentation because in the state of Oklahoma, your provider community under the leadership of your Office of Rural Health is today taking a really important first step in expanding the kinds of services and resources it can make available specifically to your small rural primary care practices. And so this will be a process starting today that will take some time to stand up a statewide performance improvement network. But what we wanted to do on today's call, because there is so much disruption and uncertainty around a piece of legislation that was passed in late December, we wanted to start off with an overview of that piece of legislation and some of the potential issues that it may raise, specifically with critical access hospitals that own and operate provider-based rural health clinics. The second thing we want to do as part of this kickoff is to talk to you about a broader set of programming opportunities that will be made available to you through the Office of Rural Health and the data platform that we're going to stand up that will allow us once and for all to address the challenge that I think many of us have been facing, which is we don't have a lot of information around performance for rural health clinics. And we want to fill that data gap as part of setting up this statewide performance improvement network. So with that as background, we wanted to spend the first 25 minutes or so talking about something that is incredibly important and that really hasn't received, we think, adequate airtime, specifically for the small rural hospital operators. So with that, my colleague at Stroudwater, Jonathan Pattenberg, is going to share with you all the updates and the impacts of the legislation from late last December.
Thanks, Greg. So as we talk through the information today, as Greg had mentioned, we're going to be focusing a fair amount of time on what has changed and how specifically those changes are rolling through the industry. Now, again, it's not to address any of this from a political perspective or to say whether or not it should or should not have changed. It's really to address and evaluate what are the specific impacts of this change on the healthcare industry. As you have questions today, please enter them in the chat box or whatever you'd like to do, as I'd rather have a conversation or at least be able to address any of those questions you may have as we work through this information today. So as we talk about the information today, again, it's talking specifically about how the RHC reimbursement methodology has changed going forward. Now, on December 27th of 2020, the Consolidated Appropriations Act of 2021 was signed into law. And buried within that roughly 6,000-page bill was a substantive change to the RHC reimbursement methodology going forward. And this is something that will impact all RHCs going forward. It's not something that's only going to impact one segment or a small grouping of the RHCs. Now, starting on April 1st, which was a week ago, all new RHCs, doesn't matter if you were a fewer than 50 bed, greater than 50 bed, or an independent RHC, all new RHCs that were established after December 31st, 2019, will be subject to a new upper payment limit threshold going forward. Now, for our fewer than 50 bed RHCs, The upper payment limit is different than what we have received in the past. So in the past, any RHC that was owned and operated by a hospital with fewer than 50 beds used to receive an uncapped cost-based rate. Going forward, again, all RHCs that were established after that December 31st, 2019 will be subject to an upper payment limit. And you get the lesser of the two. So in an upper payment limit environment, if your cost-based rate is $150 and the upper payment limit's $100, you get the $100. If your cost-based rate was $85 and the upper payment limit's $100, you would get the $85. So again, it's the lesser of the two rates. Now, on April 1st, that rate is $100 and it'll trend to $190 by 2028. And then in subsequent years thereafter, the rate will increase based on the Medicare Economic Index, the MEI. And in 2021, the MEI was actually 1.4%. Now, for any RHC that was owned and operated prior to December 31st or on December 31st of 2019 will meet a grandfathering provision. And in the grandfathering provision, they will take your 2020 rate, and that will be established as your basket rate there forward. Now, if your 2020 rate was $200 a visit, that will be your starting point for that future reimbursement rate. And then thereafter, it will trend forward based on the MEI. So if your rate was $200 in 2020, you would take that $200 and multiply that by the 1.14% or the 1.4%, and that will be your annual increase for that year. Now, there has been a fair amount of conversations around the grandfathering provision, and there have been two bills that have already passed to rectify the grandfathering date. But nonetheless, unless there is legislative change, what was passed as a part of that Consolidated Appropriations Act will remain and be in effect. So again, any change to this will require specific legislative change to change either the grandfathering date or any future reimbursements because it was written specifically into the federal law itself. Now, when that bill was passed, the grandfathering date raised a few different concerns. Now, the first major concern is that there were 295 new RHCs established in 2020. Of which 153 were provider-based RHCs. So again, a provider-based RHC is an RHC owned and operated by a hospital with fewer than 50 beds. Now, you can also have hospital-based RHCs, and hospital-based RHCs would also then include the provider-based RHCs, but also RHCs that are owned and operated by hospitals with 50 or greater beds. So I just wanted to distinguish the difference between a provider-based RHC and a hospital-based RHC. Now, again, unless there is legislative change, those 153 RHCs that were established as provider-based RHCs in 2020 would be subject to that $100 upper payment limit that started on April 1st. Now, there was a bill that passed out of the Senate sponsored by Senator Warren out of Virginia. Now, that bill actually would address, if it passed in the House also, to change the grandfathering date to December 31st of 2020. So that would address all of those practices that did convert in 2020. There was also a bill that passed out of the House, and the reason that the final bill has not been passed and signed is because the bill that passed out of the House is different than the bill that passed out of the Senate. So the bill that passed out of the Senate has gone back to the House, and it looks like that bill should hopefully pass around April 15th through the 20th, depending upon the congressional cycle of evaluating that bill. Now, in addition to all of those clinics, there were also several hospitals that had filed their 855As, and we consider those in process. Now, through whatever reason, they were not able to actually get surveyed prior to the grandfathering date. Unless, again, there is that legislative change, all of those clinics that had filed their 855As but had not actually been surveyed by 12/31/2019 would also be subject to that upper payment limit. Now, the Warner bill that did pass out of the Senate did include that as an ability to qualify for the grandfathering provision. And it stated that any clinic that was owned and operated by 12/31 or had filed the 855A by 12/31/2020 could meet that grandfathering provision. So hopefully that will pass out of the House, and then that could end up changing that going forward. Now, the third area is there's several hospitals across the country and RHCs that had started capital projects. Now, because the RHC program requires you to actually be in operation when you file the 855A, many of those hospitals and clinics could not file their 855A prior to the grandfathering date to meet that requirement. All of those clinics will also be subject to that upper payment limit going forward. Now, the reason why this creates concerns is it's created an environment for many clinics where the rules of the game were changed after organizations had actually gone through and started specific initiatives, whether you started a capital project or started the RHC process, or had actually converted after the grandfathering date that's currently established. All of these clinics will now need to reevaluate to determine if the RHC program is the most viable option going forward for those RHCs. Now, the last area is really around the grandfathering provision. And what I want to highlight here is not to say that RHCs that are grandfathered are 100% at risk, but really to identify legal precedents that has been established that impacted another type of provider designation under Medicare. Now, in 2015, as a part of the Bipartisan Budget Act, the federal law clearly created a grandfathering provision for off-campus provider-based practices that were receiving the APC payment, the ambulatory payment classification payment, that were in operation and billing prior to November 2nd of 2015. And it stated that after January of 2017, all of those practices that were grandfathered would continue to receive the full APC payment there forward. Now, unfortunately, as a part of the 2019 OPPS final rule, CMS came out and said they were going to apply their site-neutral payment policy to all of those grandfathered practices. And they said, even though it was written in federal law, it was within their discretion under the site-neutral payment policy perspective to apply site-neutral payment policy to those grandfathered practices. And they were going to reduce the APC payment by 60% over a 2-year period. So 30% in 2019 and 30% in 2020. So they ended up implementing that rule. Well, the American Hospital Association ended up suing and stating that because it was written in federal law that the HHS secretary did not have the authority to apply site-neutral payment policy. They won the original lawsuit. However, CMS ended up appealing that decision to the U.S. Court of Appeals, the D.C. Circuit. And the D.C. Circuit of Appeals actually stated that it was within the CMS's unilateral authority to apply the site-neutral payment policy to those grandfathered practices. And they said that because the federal law did not expressly prohibit the secretary from applying site-neutral payment policies, and the services could be just as easily provided in both locations, and the only difference was one was grandfathered and the other was not, that the secretary could apply that site-neutral payment policy. Now, again, this does not say that RHCs are 100% at risk going forward because they are now grandfathered. But what it does do is create an environment where legal precedence has been established to state that the Secretary of HHS does have the authority to apply site-neutral payment policies to grandfathered practices. So it'll be unknown as to whether or not this will actually occur in the future. However, there always is a level of risk, no matter how small that risk is, that eventually one day that they could take that same position regarding the RHCs, just like they did with the provider-based practices. Now, if that did ever occur, most likely it would go to court, but nonetheless, it would create an environment where you are having to argue from a legal perspective what is and is not within the legal authority of the Secretary of HHS from a site-neutral payment policy perspective. Now, again, I'm not saying here by any of these arguments or conversations that we should reverse or take away the increase to the independents in the greater than 50-bed hospitals. Again, it's just highlighting the relative risk and identifying concerns that we need to be thinking about now that the law has changed itself. Now, when we look at specifically to critical access hospitals, the change in the RHC reimbursement methodology has a outsized ability to disproportionately impact critical access hospitals more than any other designation type. It's not to say that this is not a viable strategy or that it's not the most optimal strategy from a designation perspective. Again, it's just to highlight the concerns relative to the critical access hospital program now going forward because of that change in the RHC reimbursement methodology. Now, critical access hospitals by nature should receive cost-based reimbursement from Medicare and in some states Medicaid for the services that are covered under that CAUSE program. Again, you have to carve out all of your professional services that you're billing fee for service, but nonetheless, they receive cost-based for many of the services. This change in the law has now changed a cost-based program to a non-cost-based program for critical access hospitals going forward. Now, when we look across the country, there were 890 of the 1,350 critical access hospitals. So overwhelming majority of CAUSE own and operate at least one rural health clinic. And in fact, those 890 CAUSE own 1,650 of all RHCs across the country. So greater than a third of all rural health clinics across the country are owned and operated by a critical access hospital. And again, we have now changed a program from a cost-based program to a non-cost-based program. And the concern with this is that many critical access hospitals across the country operate at near break-even margins. No critical access hospital in wide proportion turns significant margins on their bottom line. And a huge portion of that is because critical access hospitals receive cost-based reimbursement from a significant portion of their payer mix. So when we look across the fact that now this program has been switched from cost-based to a non-cost-based program, any year where the critical access hospitals RHCs have a cost increase in excess of that MEI, that will be lost reimbursements from Medicare and margin they will have to cover from other services within their hospital. Now, when we look across those 1,650 RHCs, what we looked at is we pulled all critical access hospitals cost reports that owned and operated RHCs. And in 2019, there were 750 RHCs that saw an annual cost increase in excess of that 1.4% MEI that just came out in 2021. Now, when we ran those cost reports, first what we did is we carved out all clinics that were not in operation for at least 3 years. And the reason we did that is we wanted to remove the variability of rates that may occur within the first or second year of establishment. And we wanted to have a more normalized environment. But nonetheless, for those 750 RHCs that saw a cost increase in excess of 1.4%, they will have to cover that lost margin through other services within the hospital. Now, when we look at that, to put that in different perspective, the annual cost increase for a critical access hospital is between 3 and 5%. However, for those RHCs, they were capped at 1.4% in their rate for 2021 if they were grandfathered. So if you saw a 3% cost increase and you're capped at 1.4%, that means you're going to lose that 1.6% in reimbursements due to the capping on that upper payment limit going forward. Now, when we look at critical access hospitals specifically, the reason why the RHC program switching to a non-cost-based program going forward can disproportionately impact those critical access hospitals is due to the fundamental approach of the cost report. Now, under the critical access hospitals cost report, when we have rural health clinics, those rural health clinics pull down overhead costs away from other cost-based services, away from med-surg, your emergency department, and all of those other programs that you would be receiving cost-based reimbursement. And the reason why they disproportionately impact those critical access hospitals is because under the rural health clinic program, you leave all provider compensation in when you're actually calculating your overhead allocation. If that clinic was a provider-based clinic, you would have removed all of that provider compensation out before doing the overhead allocation. Now, when we look at the example up on the screen, we can see that there is a provider-based clinic and a provider-based rural health clinic. And we looked at the impact to how that would impact the A&G step down on the cost report. So there was a $2 million clinic, and there was about $960,000 in provider compensation. Under the provider-based clinic, you would remove that out before you determine the overhead allocation. Under the rural health clinic, you leave that in. So this rural health clinic ended up pulling out about $104,000 more in overhead allocation that was then applied to that rural health clinic. Now, if you are 50% cost-based as a critical access hospital, that difference in reimbursement, if you're in excess of the grandfathering provision, could be upwards of $50,000 a year in lost reimbursements that you would have received from other cost-based programs. So again, this can impact your organization going forward. It's not to say, again, that the strategy is not viable. It's really just to explain how these can impact your organization going forward. Now, when we look at Oklahoma-specific information, in 2020, there were 100 RHCs across the state based on the provider of services file from Medicare. Now, 15 of those clinics were independent, and 85 of those clinics were hospital-based. Again, hospital-based is any clinic that is owned and operated by a hospital. Now, of that 100 total, 11 RHCs were established in 2020, with 10 being provider-based RHCs. So for the 10 provider-based RHCs that are up on the screen, unless there is that legislative change, changing the date to 2020, all of the new RHCs that were established would be subject to that $100 upper payment limit that went into effect on April 1st. So for the 10 RHCs that were established, very important that you engage your congressional delegation around the importance of what this will specifically do to your reimbursements going forward. It is unknown how many clinics were actually in process. So we don't know, are there 10 clinics in process? Were there 50 clinics in process? Nonetheless, all of those clinics, because they were not able to get under that grandfathering provision, will be subject to that upper payment limit going forward. Now, in 2020, again, there were 23 CAs across the state that owned and operated 47 RHCs that will be subject to that upper payment limit going forward. So your critical access hospitals right now own roughly 50% of all RHCs in the state of Oklahoma. Even if you're grandfathered in, those RHCs will be subject to that upper payment limit increase of that MEI going forward. Now, what I want to talk about is specifically how the change in legislation impacted reimbursements for organizations. So what I ended up pulling on the screen is what I wanted to do was say, what would have happened if this law went into effect in 2015? And 2016 was the first year that we could actually look at the rates going forward and how would that have impacted reimbursement rates. So first, we're going to talk about a critical access hospital that owns and operates 2 rural health clinics. So in 2016, their cost-based rate was $155, and that rate increased to $220 in 2009. Now, based on that grandfathered upper payment limit, their increase is capped at that 1.4% increase a year. So we can look at that by 2019, their cost-based rate was $220. However, capping that increase going forward, they would have been at $161. Over this 4-year period, this fewer than 50-bed hospital that owned and operated 2 RHCs would have lost out on nearly $700,000 in reimbursements because of the change in the RHC methodology. Now, on the table on the bottom, this looked at either an independent or a hospital-based RHC that had in excess of 50 beds. So this hospital actually owned and operated 2 RHCs also, and their cost-based rate was about $145. Now, in 2016, they were subject to an $81 upper payment limit. Now, based on the change in the RHC methodology, their rate is going to go to $100, then $113, $26, $39. So this greater than 50-bed hospital would have increased over that same 4-year period $331,000 in reimbursements. So what this is really showing is what the law has done is it did not address the cost of healthcare. It did not address anything from that perspective. What the law has really done is it funded an increase to the independents and the greater than 50 beds by capping the reimbursements on the fewer than 50 beds. So all it did was move around the reimbursements among the providers, but did not address anything else with regard to the program itself. Now what we want to look at is those same two organizations, the critical access hospital and the greater than 50 bed hospital. Again, whether it's a greater than 50 bed or an independent, the impact would have been the same. Same thing for the critical access. We could have picked a 45 bed hospital and the impact would have been the same on them also. But what this slide now looks at is saying, okay, what would have happened if this hospital that owned and operated clinics wanted to create 2 new RHCs going forward? So the rate would have been the same, $155, and it would have trended to the same $220. However, they would have been subject to that new $100 upper payment limit cap going forward, and that would have trended to $139. From an opportunity perspective, the difference in reimbursements for this fewer than 50 bed hospital would suffer an opportunity cost in reimbursements of about $1.3 million over that 4-year period. Now, again, this is not to say that the RHC is not still the best program. All this is comparing is the difference in reimbursements under the prior model versus the current model. It's not looking at the difference in reimbursements between, say, the new RHC model and, say, a freestanding clinic that's only billing fee schedule. Again, this is an opportunity cost relative to the program itself. The bottom grouping, again, the benefit would be exactly the same because their rate is going to the $100, trended up to the $139. So this RHC down here would have gained the same $330,000. So what has happened with the change in the law is it's limited future exposure to Medicare by capping the increase on the fewer than 50 beds and use some of those savings to actually pay for or subsidize the increase to the greater than 50 beds in the independent clinics. Now, the last area of how this will actually impact organizations going forward is, from my perspective, I think it will fundamentally change how and who leverages the RHCs going forward. Now, in the past, with the prior reimbursement methodology, there was a specific financial incentive for larger hospitals and organizations to partner with smaller hospitals and organizations to actually leverage the RHC program as a means to increase revenue and sustain the delivery of services throughout rural communities. And that was really done in 2 ways. One is the prior reimbursement rate for fewer than 50 beds was an uncapped cost-based rate. So that was one of the advantages. The other advantage is that many smaller organizations would qualify for 340B reimbursement or 340B revenue. So you had a 2-pronged approach as to how these larger organizations were actually incentivized to work with those smaller organizations. Going forward, carving out the grandfathered practices, but going forward, all RHCs have the ability to get the same upper payment limit going forward. You would all start at $100 this year and trend to $190 in 2028. An important distinction is the fact that from a 340B perspective, there is a difference between the CMS provider-based requirements and the HRSA child site requirements. And there is a gray area between the two. And to really explain that gray area, at a high level, generally, all provider-based clinics, inclusive of provider-based rural health clinics, will meet the HRSA child site requirements for 340B purposes. However, not all clinics that meet the HRSA child site requirements will meet the CMS provider-based requirements. And the rural health clinic program is a perfect example of that. So CMS will not make a provider-based determination on any rural health clinic that is owned and operated by a hospital of 50 or greater beds. It actually states that in federal regulation under the 41365. However, a rural health clinic that meets certain child site requirements can qualify for the 340B child site requirements because the RHCs that are owned and operated by hospitals with greater than 50 beds includes that RHC on their cost report. The expenses are showing up on worksheet A and the charges show up on worksheet C. So what this will do going forward is, because the upper payment limit is going to increase to $190 and the larger hospitals in most instances qualify for 340B, it will create an environment where those larger hospitals can now establish rural health clinics, leverage the 340B program, and use those RHCs as a means to funnel volumes or services back to the larger urban facilities. And really, under the prior methodology, many larger hospitals and systems have leveraged this program as a means to push primary care and specialty services out to rural communities. So it's led to a decentralization of services away from urban areas into rural communities. I feel that through this program and the change in the program, that many larger hospitals will start to leverage this program as a means to re-centralize services back to urban areas and away from rural communities. And when we look across the country right now, the largest hospital that actually owns and operates a rural health clinic is in excess of 500 beds. It's a $4 billion gross patient revenue facility that owns and operates a rural health clinic. And in the past, they did that as a means to get access to 340B. Going forward, that clinic will now also qualify for that upper payment limit eventually of $190 and 340B. So what it's done is it's realigned the financial incentives throughout the healthcare industry as to who and how organizations can leverage that program going forward. It's unknown specifically or exactly how this will change the leveraging of the program, but it will change. Anytime there is a policy change at the federal level, there are always organizations and different entities that are able to actually leverage that program going forward. So I know I went through a lot of information at a very high level. I'm going to pause for a moment to see if there's any questions or anything that I could answer. If you want to either type it in the chat box or unmute yourself to ask a question, I'll give a moment, and then I'll turn it over to Greg, who's going to go into a bunch of different data from his perspective. So somebody asked, why did they think this was a good idea? I think that certain people thought it was a good idea. And I'll give a little bit of the historical background. About 10 years ago, the National Association of Rural Health Clinics started floating the idea of increasing the independent and the greater than 50 bed rate. And I completely agree that it's been artificially low or much lower than any of the other services out there. They did not get much traction around that. And about 2 years ago, they started floating the idea of a pay for. So taking away from the provider-based RHCs and using that as a means to increase for the greater than 50 beds and the independents. Now, the Hospital Association, the American Hospital Association, NRHA, all of the hospital-based organizations said that was not a good idea. And actually, 2 years ago, the Barrasso bill came out. It was called the RHC Modernization Act, was actually introduced. And in that bill, it actually talked about increasing the independent rate and the greater than 50 bed, in addition to addressing a number of other things under the RHC program. That didn't get much traction. So they continued to float NARC, National Association again, to float the idea of using a pay for from one to give to the other. It ended up getting buried within the 6,000 page bill and ended up passing. Now, again, I'm not going to get into any of the political nuances of the program, but I feel that it didn't specifically look at the long-term impact to critical access hospitals and specifically those fewer than 50 bed hospitals. And I think that that's why it was able to get traction and ended up passing as a part of that. All right, I will turn it over to Greg Wolf, who is going to go into a bunch of data now.
Thanks, Jonathan. Can you see my screen okay?
Yes.
All right, very good. A couple of housekeeping issues. I want to make sure everybody's got their phones on mute. Appreciate that. I would, Jonathan, well, first of all, thank you for that question. And Jonathan, I appreciate your answer. I would add to your answer with a little bit of a different piece of the puzzle, which is in an information vacuum, a lot of times people make a decision that may not be particularly helpful or enlightened. And I think that what happened in late December with this act was at least partially driven by the fact that in our country, we don't know enough about rural health clinics. And that's at least in part because there have been exemption after exemption after exemption as it relates to public reporting. And while that feels great because there's no obligation to collect and report data as another administrative function, it has left us in the dark in terms of just how important, how valuable the clinics are to our rural communities in our country. And what's exciting about the network that the folks at the Office of Rural Health are standing up is this is a movement to address all kinds of issues that we know are important, but one of them is starting to collect information to inform policymaking. A little bit of background, and then I want to talk about the first major piece of what we're trying to develop foundationally with this emerging rural health clinic network. I mentioned at the start of this presentation that we give a lot of credit to Laura and Corey and Pete and others at your Office of Rural Health. This really is one of the last frontiers in rural America in terms of funding, support, technical assistance. And we think it's just about time because one of the things we know will change out of necessity over the next 3, 4, 5 years, next couple of decades, is a reorientation away from straight acute med-surg hospital-based care, especially in rural America, and orienting those resources and focus, and quite frankly, strategy and operations to primary care practices. And in our country, that translates a lot of times into rural health clinics. We have over 4,700 rural health clinics in our country, and that's great, but we think it's time to start committing a proportionate amount of focus and energy toward those clinics. So that's a little bit of the background. Now, what we are going to do is over the next several months and perhaps into the next several years as we build out the network for the rural health clinics, is we're going to provide a nice mixture of technical assistance support through consulting with groups of hospitals and their clinics and rural health clinics, the independents, as well as build the data-based framework. So we can start understanding performance variance, start identifying how Oklahoma compares to its peer states and regionally, and try to use that information to shape projects and support that address the most acute needs among the RHCs in Oklahoma. You've got a pretty good number of rural health clinics. These numbers are a little bit older because this is actual established clinics that had submitted a full cost report as of fiscal year 19. So the number's a little different than what Jonathan shared. Jonathan was giving you the more up-to-date list of clinics that had successfully filed in their A55s and had been certified as rural health clinics. So there's a little bit of catch-up intrinsic to this slide. But Oklahoma's got a little bit more provider-based or hospital-owned rural health clinics relative to independent clinics than the national standard, which is around 73% we see as provider-based. Now, what I'm not going to do out of the interest of time, is to use this webinar to start drilling into all kinds of benchmark data, but we have a lot of benchmark data. What will happen over the next series of months is we'll work closely with Laura to set up the curriculum and the webinars as part of the development of this network. What I would share with you, just as a series of quick fun facts, and again, you'll get this information over time. When we look at the provider-based rural health clinics, our friends at CMS have set minimum productivity standards, meaning we, for the purposes of full cost-based reimbursement, CMS expects full-time equivalent physicians to see 4,200 patients a year. And then for the advanced practice providers, the expectation is a minimum of 2,100 visits per year. When we look at the Oklahoma rural health clinics that are owned and operated by the critical access hospitals and the hospitals with 50 or fewer beds, only 56% of those clinics meet those most basic minimum productivity standards. And I offered that as one of multiple rabbit holes that we will end up going down over the next several months and years as we start focusing on areas for improvement across the state. The result of that, just in case you're wondering, is when you are a provider-based rural health clinic and you do not meet your minimum productivity standard, you will not get full cost-based reimbursement for Medicare or Medicaid. Now, in the state of Oklahoma for 2019, and again, that's the year for which we have a full census of full electronic cost reports available to us, and that's over $4 million a year that the state of Oklahoma gives back, if you will, just to Medicare. And that's simply as a function of the way you've established the designations of certain clinics, but primarily the fact that you're not meeting your minimum productivity standards. I'll also share with you that the productivity, the average number of visits for a full-time equivalent doctor, as well as an APP in Oklahoma, is actually pretty significantly lower than your peers in your geographic region. And I'll also share with you, however, that your cost per visit is significantly lower than your peers. And so we'll look at the interactivity of all kinds of metrics to start to paint a picture of Oklahoma and then drill into individual practices. So no shortage of data on our end. And again, you'll over time start to see these kinds of information shared with you. We're able to collect data from a lot of clinics. And so from a cost report perspective, we're able to collect data for every clinic in the country for the last 5 years. These are the states that are participating with us. So we've got a growing list of proprietary data that we're able to look at too. And when I say proprietary data, that's the system that we have developed and that the folks at the Office of Rural Health are using to help guide the formation and the programming, the curriculum, if you will, for the RHC network. And so the program is called POD. It stands for Practice Operations National Database. This is a service that's available to every rural health clinic in Oklahoma at no cost. We'll get to that in just a couple of minutes. It has two basic parts to it. One part is based on publicly available data, principally cost reports. The other side allows us to collect the information that we do not have available to us in the cost report. And so there we ask for things like compensation and productivity, as well as profitability and staffing model information. We only ask clinics to give that to us one time per year. It will take you about 20 minutes. So we're hoping every clinic can find 20 minutes in the full arc of a 12-month period to help build the database. And for those of you who are responsible for working with your advanced practice providers as well as physicians on contracts and compensation, you probably are familiar with the product called MGMA. It's the gold standard, the national standard. It's great. We use it all the time for our larger practices. But the problem with MGMA is it doesn't have a lot of rural health clinic data. And so think of this as a rural health clinic-like equivalent to MGMA. So what I'm not going to do on this call is I'm not going to give you a demo. I'm not going to walk through the tool and how it works. We're going to ask you to do that at your convenience because we've got a nice 28-minute recorded webinar that's posted online. So as a practice manager, when you get a break in the action, you can go out and watch this video. It's broken down into very easy to understand components. The first one is what is POND. Then we talk about how to enroll your clinic. We talk about the data we ask you to provide us, and then how to do your reporting in analytics. And again, you'll have these slides. You'll have an active link. And this is what we'll ask you to do to enroll your clinic. Find 20 minutes. Well, I'll tell you, the harder part is just getting the data organized. But take 20 minutes to put the data into the system. And then what you'll have available to you is all kinds of reporting and analytics. And again, it's available to you as we speak and at no cost to your clinic. We want to get as many of the 93 RHCs in Oklahoma up and running and using POND. Once we do that, we'll be able to provide all kinds of programming and educational resources available to you, very similar to what currently is available through the FLEX program and the critical access hospitals in Oklahoma around finance, operations, and quality. We really want to build off that and make those resources available to rural health clinics. When we think about education and training and the kinds of resources we want to make available to practice managers and at times CFOs of the rural hospitals, we're able to break those down into 10 major areas. So you can see what those are here. So think of this as a table of contents for the programming that will occur over the next year or so. I've highlighted one of these, contracts and compliance, because this is a particularly important area of focus and need in the context of COVID and the disruption that wrought to volumes in our rural health clinics, as well as the reorientation of the kinds of services offered, including telemedicine, but also the amplitude and the shocks in the volumes in rural health clinics as a function of COVID. What that has done is it has brought to light the fact that a lot of contracts that have been set up for rural health clinics, and principally the physicians who practice in those clinics, we're not set up in a way to be durable to the kinds of shocks that we came across with COVID. And so what will happen as probably the first webinar and set of projects will center on contracts and compliance with your providers for rural health clinics. Laura will talk to you about a process for identifying a small subset of rural health clinic locations in Oklahoma who will be able to work directly with Opal Greenway from Stroudwater Associates on actual projects to look at your contracts and identify opportunities to get those both into compliance if they are not in compliance, but also share best practices on how to structure and monitor those contracts with your providers. So more on that to come. But if you look at this list of 10, the first item that will come out to you as a nice formal set of resources and best practices, and then again, some pilot projects, that will be the contracts and compliance. Last thing I want to talk about is the Lilypad Awards, and we think this might be interesting to you. And so what we do with Lilypad, Lilypad is the company that creates and maintains the POND program, which will be used as the data platform and foundation for the Oklahoma RHC network. What we do is, because we've got all the cost reports for the last couple of years, is we have run some numbers on these 5 metrics you see here. We've weighted the metrics a little bit differently. We think some of these are stronger drivers than others. But we've run the numbers on every clinic in the country. And then every year in January, we release a list of the top 50 rural health clinics in the country. We do that by breaking the U.S. out into its 5 regions. Those regions are based on the National Organization of State Office of Rural Health regions. So Oklahoma is in the Southwest. For every one of these regions, we identify the top 5 provider-based RHCs and then the top 5 independent RHCs. When you add that up, you get to 50. So we name 50 top clinics in the country. What I would share with you is for every rural health clinic on the call today, we have your national rank and your percentile score as one of several reports that are available to you right now. And again, there's no cost. All right, last slide, and then we'll wrap things up. For those of you who want to think about and look at best practices in different areas of priority for rural health clinics, you can go out to the Lilypad website right now and you can either watch a 30-minute video on one of these topics or download the slides. And we like to think of this as a primer, a set of pretty easy to watch videos around best practices in each of these different areas. And again, just go out to lilypad207.com, click on webinars, and there you go. You can watch those or download those at your convenience. Okay, last slide. What's next? Let me go with this slide, Laura, and then if you want to wrap us up and give us a little bit more of Oklahoma-specific details on what's going to happen next, we'll do that. If you are a critical access hospital leader and or a rural health clinic practice manager, and you have not already enrolled in POND and put in your data, we are asking you to do that. And this is our first key step because we want to be able to collect some proprietary data specific to Oklahoma's RHCs, because that will help Laura and our team identify what things to work on first. And so our ask of everybody on the call is to go out and view the online tutorial so you can see how it works, the website. Enroll your clinic, enter your data, and generate reports. And there's all kinds of reports that are available to you. So you're going to have a summary report that will show a bunch of productivity and compensation as well as financial and staffing metrics. That comes from the data that clinics provide us manually. You're also going to get access to a site audit. So we're going to do some review of your cost report to see if there's any data integrity issues and errors. In Oklahoma, there are a lot. So we'll do an audit from that perspective. You'll also get a cost report scorecard that'll show you the last 3 years. So your trend in statistics relative to Oklahoma regional and national peers. And then again, you'll also be able to get, using those 5 metrics, your 2021 Lilypad Award report that'll show for your specific clinic, your rank and your percentile score. So we have a very specific, I was just going to finish up and then I'll open it up to questions or I'll review the chat. I want to be very clear and very candid. We have an ask of every rural health clinic in Oklahoma. We want you to be an active member of this network. We want this to be an incredibly important resource for you to meet your peers, learn from them, and use this as a way to gather friendly hints, recommendations, and best practices to make your RHCs as good as they can be. That starts with providing us some data so we can start sharing back to you information, but also use that to prioritize the curriculum. So there is an ask. We want you to enroll in POND and put your data in. So with that as background, Laura, do you want to wrap us up and then let me
look
have some questions?
you got some questions in the chat box.
All right, I'm too busy rambling on, but let's go ahead and let me look at those. Okay, so I got Jason's first question. We took care of that. Jonathan, I think you probably need to respond or should respond to Mindy's question. So was it a mistake to change to RHC fewer than 50 beds? We were certified July of 2020. Jonathan, you want to take Mindy's question first?
Yeah, I would say it's not a mistake. I would say it's a 99.9% chance that the grandfathering date will change to 12/31/20. And in that event, if it changes to 12/31/20, you would then meet the grandfathering provision, which means your cost-based rate in your first year would be used to actually establish that rate going forward. If you were greater than 50 beds or 50 beds, you would have been subject to that $100 rate going forward. Now, if when you get out to 2028 and you find out that you are going to get the same $190 rate regardless whether you're fewer than or greater from that perspective, then you can reevaluate then.
And thank you, Jonathan. And hearing you respond to that question, what I don't think we shared in a very explicit manner, so let me be plain. Jonathan and I, we work with Stroudwater and as well as Opal Greenway. So we're the group of folks who will work very closely with Laura and Corey on the development of this network. We have a contract with the Office of Rural Health. Our job is to help the clinics as much as possible. So if there are clinic managers or CFOs or CEOs on the call and you have questions about anything that was covered on this webinar or just general questions, I'm inviting you to contact me, Greg, or Jonathan, and set up a call or ask us a question. Our job is to make sure that in Oklahoma, clinics and hospitals that own clinics are getting the resources they need to do the best job they can. So that's an invitation and an encouragement to everybody who's on the call. All right, two more quick questions, and then Laura, if you can wrap up. First question is, can we get a copy of the slides? Yes, a recording of this presentation as well as Jonathan's slides and my slides. We'll get those to Laura, and we'll ask Laura to disseminate those sometime later today or tomorrow morning. And then, is there an expense related to POND? There is no expense for POND, and nor is there an expense that I'm aware of, Laura, for any of the programming that we're going to offer or any of the technology.
No, there's no cost for the clinics. This is sponsored by the Office of Rural Health.
Thanks, Laura. Jason's asking another question. So while we before we do put a punctuation mark on this, Jason's question is: bottom line, if we open another small clinic in a rural area, we are subject to a $100 cap question with a limit of only 1.4% increase per year. Jonathan, you want to handle that question from Jason?
So you'll be subject to that $100 cap in 2021. The rate increase is $13 a year and then $12 the last year through 2028. So it'll go from 100 to 113 to 126 and so forth. The 1.4% cap applies to the current grandfathered practices or any practice that is new after 2028. It would then be subject to that 1.4% cap thereafter.
Thanks, Jonathan. Laura, do you want to wrap us up? We're right at 11 o'clock your time, and we've asked people to give us just an hour. And so, unless there's more questions, I'm happy to close this out, and then we'll work on our next steps.
All right, absolutely. Thank you guys again for joining us today. We did have another question that significantly limits the ability to bring a qualified provider to a rural area, doesn't it, with the cap?
Well, it depends on the provider. If you're going to bring in APPs or whatever, it's a much more comprehensive question. At the highest level, it could limit the ability to bring new providers, but again, it's not an across-the-board approach that'll limit the ability to bring all providers.
All right.
Laura, in hearing this question, one of the things, and maybe we can talk about this a little bit later, but to the group who are on the webinar here, if you have an interest in setting up a time for us, and maybe this will be the first webinar, we're happy to go over the nuts and bolts and mechanics of finance and operations of rural health clinics, perhaps with an emphasis on provider-based rural health clinics, and just have it as an open, almost office hours format, where we'll share with you all those best practices and the things we think you really need to know, because this is a fluid situation right now, right? What we've got going on with the legislation. But we're happy to set up a webinar and just have it be a forum where people can ask any kind of question they want. And we're happy to do that. Our obligation is to answer your questions and make sure that all these clinics are spinning like a top to the extent possible.
Greg, I think that's a great idea, because I know, especially this topic, it seems to be changing with new information coming out almost every week. But thank you guys again for your time. Thank you, Greg and Jonathan, for your expertise. We have a question. What classification would a new RHC established in the same geographic region, but under the umbrella of the original provider-based RHC?
I don't really know. I'm not sure what exactly that means.
Or actually, I think it's fair. Would the caps or grandfather apply?
Okay, so if you add additional providers under a grandfathered practice or were to roll in a specialty, again, each RHC is evaluated as a standalone RHC itself. So if you were to add new providers in, or you were to expand the number of suites, maybe you're in a medical office building and right now it has 3 suites and you're going to expand it to 4, that would all be under the same RHC itself. So it would be subject to that grandfathered rate going forward. Because again, the RHC is the designation, not the provider itself.
All right. Well, thank everyone. I know we're a little bit past the hour. My next steps are I'll get the slides from Jonathan and Greg. I'll send those out to you guys, as well as the link for Lilypad, or for POND, to get going. If you registered, years ago, but have not logged in, this might be a great opportunity to get it back in there, update some of your data, update some of your contacts. If you are a clinic that is thinking more about working with OPPL for the compliance and contracting, let me know, and we can get you on the short list for that. With that said, please be checking your inboxes for information coming about. And if you would like to schedule like an office hours call with Greg and Jonathan just to pick their brains, please let me know as well. And again, thank you all for your time. We're really excited about working with y'all.
Thanks, everybody.